It's a great honor to me to introduce Professor Rajeev Chawla, is the immediate past president of the Research Society for the Study of Diabetes in India and the director of North Delhi Diabetes Center. He specialized in diabetology and general medicine. The talk
Yeah.
title
Good
is
morning,
Diabetes
everyone.
and Pregnancy,
At the
Gestational Diabetes, right from screening, diagnosis to pathophysiology to management. He is, yes, Professor, you, the mic is you. You can start. Do you listen me? Professor G, do you, you can start now.
It's a recorded lecture. You can please start it.
You can start, yes, yes.
Yeah. Good morning, everyone. At the outset, I'm extremely thankful to Professor Inas and entire organizing committee of ASD for having given me this opportunity to be part of this very prestigious international conference year after year. Task assigned to me is to today discuss in detail the entire management of GDM, starting from its pathophysiology, its management, screening, diagnosis, and the options of various drugs which are available in management of GDM. So I'll try to make it very, very comprehensive so that I'm able to cover it in less than 20 minutes. We all know that there is a rising prevalence of type 2 diabetes, and if you follow these 2021 IDF figures, more so in Southeast Asia as well as in Middle East, there has been an exponential rise in prevalence of type 2 diabetes, and so is the rising prevalence of hyperglycemia in pregnancy. Today, we have close to 21 million females living with hyperglycemia in pregnancy, and it accounts for almost 16.7% of all live births in which there is a hyperglycemia of some extent. And most of these females, they have GDM, that is gestational diabetes, which accounts for 80 to 85% of all patients living with hyperglycemia in pregnancy. As I said, situation in Southeast Asia and Middle East is even grave because as per 2021 IDF figure, the prevalence of hyperglycemia in pregnancy in Southeast Asia at least is close to 28%. That means every 1 in 4 live births are affected by hyperglycemia in pregnancy. So if you classify hyperglycemia in pregnancy as per WHO and FIGO guidelines, hyperglycemia in pregnancy, HIP, could be a pre-GDM. That means women with known type 1 or type 2 diabetes or rare form of diabetes before pregnancy it is there and they conceive. Second is DIP, that is diabetes in pregnancy, pregnant women with hyperglycemia that were for the first time diagnosed during pregnancy, more so in the first trimester, with an HbA1c done, which is on the higher side, and they meet criteria of WHO for diabetes in non-pregnant state. And this is how it is detected for the first time during the first trimester itself. GDM is any degree of hyperglycemia which gets detected for the first time during the antenatal period. Well, Caucasians say it is close to 24 to 28 weeks, but in Southeast Asia and I'm sure even in Middle East, many of our pregnant females, they tend to have GDM as early as 12 to 13 weeks. And if you do their HbA1c to differentiate them from DIP, their HbA1c is absolutely normal. It may be less than actually 5.5. As I said, Indian women, they have a very high frequency of having GDM, and it is said that Indian women have 11-fold increased risk of developing glucose intolerance during pregnancy compared to Caucasian women. That is why in India we say that there has to be a universal early testing in population with high prevalence of type 2 diabetes. That means every female whosoever gets pregnant, once she comes for the first ANC visit at 12 to 13 weeks, must be screened for GDM. And this is what we follow as per Ministry of Health and Government of India, because this is based on Diabetes in Pregnancy Study India Group, where it is said that every female must be screened in the first trimester itself. So we in India follow a DIPSI procedure, which is a single step procedure. 75 gram of glucose is given orally. It is dissolved in 300 ml of water, irrespective of fasting or non-fasting state and of last meal, and immediately that has to be taken in 5 to 10 minutes. and sugar is tested at 2 hours sharply. If there is a vomiting within 30 minutes of intake, a repeat testing may be done on the next day. But if it vomiting happens after 30 minutes of taking oral glucose, then you may continue with the test. And if at 2 hours sugar is more than 140 milligram, single reading more than 140 milligram, it is considered to be not only the screening but for diagnostic of gestational diabetes. So this is how we follow, which has been adopted by Government of India, Ministry of Health, based on DIPSI recommendation, that every pregnant woman first needs to be screened as early as 12 to 14 weeks with a 2 hour 75-gram oral glucose. If it is more than 140, it is diagnosed as GDM and they should be managed as per the standard guidelines. If it is negative, that means less than 120 milligram, these females are need to be retested at 24 to 28 weeks and subsequently at 32 to 34 weeks, even if they are negative at 24 weeks. And anytime if it is more than 140, it is diagnosed as GDM and it should be managed as per the standard guidelines. So in India, we follow the DIPSI procedure, which is diagnosis and management of gestational diabetes by Diabetes in Pregnancy Study India Group, which has been adopted by Ministry of Health and Family Welfare, and it is also endorsed by WHO, FIGO, as well as IDF also. So let me take you through the pathophysiology of hyperglycemia in pregnancy. As there is an increase in growth of the fetus toward the end of the first trimester, there is going to be increase in placental hormones, which will lead on to RAS activation into the mother, which will induce your insulin resistance. So if there is any degree of beta cell dysfunction in the mother, that will immediately manifest as GDM or gestational diabetes. So GDM probably represents a stage of chronic beta cell dysfunction or IGT in a female who otherwise will, if it is not pregnant, out of the pregnancy state will be diagnosed as IGT or pre-diabetes. So GDM actually is a stage in the evolution of type 2 diabetes, and actually it is IGT or pre-diabetes in a non-pregnant female, which manifests as type 2 diabetes, manifests as GDM subsequently with increase in insulin resistance. So if you look upon the pattern of glycemia in normal pregnancy, you will find that in normal fasting sugar in a normal pregnant female is 71 plus minus 8, 1 hour is 109 plus minus 13, and 2 hour is 99 plus minus 10. That means 2 hour sugar in a normal pregnant female will never exceed 110 milligram. That is why it is said that anything more than 120 milligram probably may be taken as early glucose intolerance. And if after 875-gram glucose load, it is more than 140, it is diagnostic of GDM. So we know that insulin secretion during pregnancy with meal versus a non-pregnant female, you could see that as compared to a non-pregnant female, in a pregnant female, so as to maintain sugars within the normal range, there is an immediate increase in beta cell function and increase in insulin secretion, which happens as early as 30 to 60 minutes, so as to keep sugars less than 120 milligram under the physiological situation. But whenever there is an increase in insulin resistance, which actually happens because of placental hormones, which induces severe insulin resistance and increase in placental leptin, there are increased pro-inflammatory cytokines, there is an increased placental transport, and that induces severe insulin resistance. So any female who already has some amount of insulin resistance into adipose tissue and into the muscles, then obviously if already has a impending beta cell dysfunction will manifest as GDM. So increase in fetoplacental hormones, precisely growth hormone, cortisol, prolactin, and HPL, induce insulin resistance. So there is going to be a compensatory increase in insulin secretion by almost 200% in a normal pregnant female. It will keep sugars within the normal range. But if beta cells are not able to compensate for this increase in insulin resistance, they will immediately manifest as GDM. So as compared to a normal non-pregnant woman, in a normal pregnant woman, there is an immediate spiking of insulin secretion, which happens as early as 30 to 60 minutes, so as to keep sugars within the normal range. But in a female who is predisposed to GDM by virtue of some amount of beta cell dysfunction, moment there is an increase in insulin resistance by 60% at the end of first trimester, in beta cell secretion has to go up by 200%. But if beta cells are not able to compensate for that, it will manifest as delayed insulin peaking, and it is blunted, so it manifests as GDM in that female with blood sugars exceeding anything more than 120 milligram under the physiological situations. So versus the normal pregnancy in a female who is likely to develop GDM by virtue of increased insulin resistance, there is going to be a further worsening of beta cell dysfunction. There is a decreased insulin secretion, which then manifests as subsequently GDM. So with any amount of persistent hyperglycemia, maybe it is only 140 milligram, there is going to be a maternal fetal nutrient transport in the human females. Not only glucose, amino acids, ketones, and triglycerides are going to cross from the mother side to the placenta to the fetus. And this is what is going to lead on to macrosomia because of overstimulation of the beta cell. And this has been appreciated as early as 1952 as Pedersen hypothesis. So any amount of increase in macronutrient will lead on to macrosomia in the fetus and organomegaly, polycythemia, and subsequent respiratory distress syndrome. Even the Franklin hypothesis says that fetal overgrowth is actually a function of multiple nutritional factors along with glucose, which could be amino acid, triglyceride, which then subsequently lead on to macrosomia in these fetus. And subsequently, these offsprings, once they achieve adolescence, they are the one who are likely to develop metabolic syndrome, IGT, type 2 diabetes, or CVD. So it is very rightly said that an impending GDM is probably a carrier towards NCD. So GDM may be taken as mother of NCD in these females by virtue of persistent hyperglycemia. So if we are not able to ensure a euglycemia in a mother, which I told you classically at 2 hours is always less than 120 milligram, there are going to be consequences both for the fetus as well as for the mother. Maternal risk could be in the form of spontaneous abortion, polyhydramnios, preeclampsia, preterm labor, or prolonged obstructed liver or increased need for cesarean sections. There could be fetal risk in the form of intrauterine death, stillbirth, congenital malformation, neonatal hypoglycemia, greater risk for hypothermia, polycythemia, and hyperbilirubinemia. So it is very, very important that we must achieve euglycemia so as to prevent long-term maternal and fetal effects. And this can only be achieved if we intervene very, very early. Moment there is an increase in hyperglycemia in the mother, even if it is in the range of 120 to 140, which has been these days labeled as early glucose intolerance in pregnancy, or if it is classically more than 140 milligram as diagnosed by 75-gram glucose load, we must immediately start lifestyle modification, and MNT could be given a trial of only 2 weeks. But subsequently, if we are not able to get sugars within the normal range, we must start drugs, which could be an option of oral anti-diabetic drugs or insulin. So when we talk about oral anti-diabetic drugs, let me take you through this, that there are two options: drugs which will not cross the placenta, or even if that drug crosses placenta, it should not lead on to any teratogenicity, any fetal hyperinsulinemia, or neonatal hypoglycemia. So all those patients, those who are having pre-GDM, type 1, they have conceived on insulin, we need to titrate the doses of insulin. Those who are known type 2 diabetes patient, if they were already on oral drugs plus minus insulin, we must stop oral drugs and must switch on to insulin therapy immediately the diagnosis of GDM is concerned. GDM, as I told you, for the first time getting diagnosed maybe in the first or second trimester, if they are not on any drugs, obviously the best option, insulin, which remains a gold standard, but there could be option of giving metformin also, and I'll be presenting certain studies in favor of metformin also. So let's revisit all these agents. When we talk about sulfonylurea, glyburide concentration in umbilical cord has been found to be approximately 50 to 70% of the maternal levels. So there are obviously going to be higher rates of neonatal hypoglycemia and macrosomia as compared to insulin or metformin, and long-term safety data are lacking. That is why these days we don't recommend any sulfonylurea in management of GDM, and that has led to the downfall like glibenclamide, because lot of meta-analysis which have established the safety of metformin or with insulin or alone insulin versus glibenclamide, you could see that it is always in favor of either insulin or maybe insulin along with metformin. And all these forest plots in all these meta-analyses have shown that glibenclamide was not found to be safe in management of gestational diabetes. Coming to the second class of drug, that is AGIs, acarbose, there is only one RCT where there were 91 patients with gestational diabetes, but although there was not much GI side effects, these were definitely there. Acarbose was otherwise found to be promising candidate for GDM because there was hardly any teratogenicity which was found in this randomized control trial. But this is probably the only RCT available with acarbose. But again, there has been a systematic review comparing feto-maternal outcomes in patients with gestational diabetes who were treated with insulin versus acarbose. And in this, it was found that if you talk about recurrent genitourinary infections, preeclampsia, delivery at mean gestational weeks, or lower segment cesarean section or vaginal delivery, they were almost identical as were in the insulin group. And even if you talk about neonatal complication, these were again identical in the insulin as well as in acarbose group. So acarbose still seems to be promising, but we need to have a randomized control prospective trial which could establish safety of acarbose in a bigger group. Coming to TZs, glitazones, these do cross placenta. There are no studies reported in GDM, only one study that has reported with rosiglitazone, and it was found that rosiglitazone cross placenta at 10 to 12 weeks. Even animal data suggests moderate risk for embryo fetal toxicity, so it is not recommended in pregnancy. Coming to gliptins, again, animal data says that it crosses placenta and is excreted in milk also. And there is only one study which was marked pregnancy registry where they have looked into the outcomes of 8 women who were exposed to CETA or CETA with metformin, and there were little higher spontaneous abortion and one fetal death at 34 weeks. So no safety data is available for other gliptins, so it has not been approved in pregnancy at all. Coming to magletides, with netaglinide, we don't have any data at all. With the repaglinide, there is only data on 8 pregnancies, although there was no birth defects or other toxicity, but animal data again suggests that there could be a little risk. SGLT2, again, you don't have any safety data at all in human pregnancies. Coming to metformin, which still remains a core drug, if many of those patients, those who are not either willing to take insulin at all or they cannot take insulin because of certain cost or logistic issues. So metformin in pregnancy, it has been seen that at the cellular level, metformin is a positively charged molecule and it is transported across the mitochondrial membrane by organic cation transporter, which is OCT. And in the context of pregnancy, I must tell you that placenta expresses many isoforms of OCTs, and hence metformin readily crosses placenta. But investigators have not been able to demonstrate any increased embryo activity or congenital malformation after metformin administration at doses which will stimulate maternal liver AMPK. So it has been found to be non-teratogenic at all, although it is excreted in the breast milk. But again, in the infants, those who are getting milk while mother is taking metformin, levels are not found to be on the higher side at all. The only risk with metformin is that there could be slight increase in risk of prematurity into those infants born out of uh, metformin if mother is already on metformin. MIG study, which randomly assigned 750 women with gestational diabetes at 20 to 33 weeks of gestation to open treatment either with metformin or with metformin and insulin. And the primary outcome which were monitored were 5-minute Apgar score, prematurity, need for phototherapy or respiratory distress or birth trauma. Secondary outcome included neonatal anthropometric measurements, maternal glycemic control, maternal hypertensive complication, and postpartum glucose tolerance and acceptability of metformin. And in this study, it was found that metformin alone or in combination with insulin was not associated with increased perinatal complication as compared to with insulin. And actually, women preferred metformin over insulin therapy. Another systematic review, metformin versus insulin, a meta-analysis has not shown any excess fetal or neonatal complication which could be demonstrated with administration of metformin compared to insulin therapy. You could see that these were all these bars. It was on the diamond was on the left side. That means metformin was found to be absolutely safe. So the positives of metformin in GDM are that 46% of women in metformin, they of course may require insulin therapy in addition to metformin so as to get good glycemic control. And it has been seen that those mothers, those who are on full doses or optimum doses of metformin, they have shown reduced weight gain as compared to those who are on metformin plus insulin. And metformin has been found to be better in reducing both maternal weight gain during pregnancy, and subsequently the frequency of PIH also lesser as compared to the insulin. But it has not been recommended as a drug for preventing further risk of developing PIH, or maybe a further risk for subsequent pregnancies if she again develops GDM. But in the index pregnancy, it has been found to be safe, and it has been found that there could be little increase in risk of preterm birth. All these studies have shown meta-analysis of 5 RCTs, 13 RCTs, 6 RCTs, 18 RCTs, even a BMJ publication as late as 2015 coming out of 15 RCTs have shown there could be little higher risk for developing preterm deliveries, and birth weight in these offspring was little lesser as compared to those females, those who are on insulin therapy. And subsequent postnatal follow-up of metformin again has been a concern. It has been found that at 18 months of age, children exposed to metformin were little heavier and taller. Another study has shown that at 2 years, there was an increase mid-upper arm circumference, subcapsular and biceps skin fold or larger skin fold thickness at 2 years in offspring born out of metformin. And at 9 years, those children who were exposed to metformin, their had been a larger waist circumference, waist height ratio, BMI, and triceps skin folds. And even a meta-analysis including 10 randomized trials have shown that at 9 years, children exposed in utero to metformin are heavier as compared to controls or as compared to those who were on insulin. So a word of caution is that although metformin has been found to be absolutely safe and effective, but it is still linked to less weight gain in the mother and little lower risk of neonatal hypoglycemia compared to insulin. But offspring born out of metformin therapy are likely to have small for gestational age, and there could be little increase in preterm births in these offsprings once they are exposed to metformin. If mother is already on metformin for management of GDM, and these neonates are then likely to have acceleration of postnatal growth resulting in higher BMI, which I alluded to in the previous slide, even at 2 years and at 9 years. Another study, which is Empower study, that has again looked into whether insulin sensitizing drug like metformin improves fetal and maternal outcome in obese pregnant women, those who are not having diabetes. That means whether it can be used in obese pregnant women so as to reduce weight gain in those females. Again, it was found that neonatal outcomes and maternal outcomes were identical, but that data is still not good enough to say that it can be given in obese females, those who do not have otherwise hyperglycemia per se. Another study which has again looked into metformin versus placebo from first trimester to delivery in polycystic ovarian syndrome, because many gynecologists, they want to continue metformin in females, those who are conceived out of PCOS. And this multi-centered study actually looked into that. And again, it has shown no effect of metformin on the prevalence of subsequent risk for developing GDM or preeclampsia coming out of that index pregnancy. Otherwise, outcomes were almost identical when it comes to neonatal and maternal outcomes. So neonatal head circumference was larger in metformin treated group as compared to the placebo even in this trial. Another important trial, which is MITI trial, metformin type 2 diabetes pregnancy, which has again looked into the difference between groups which were either on metformin versus placebo, and they looked into neonatal mortality and overall morbidity. Metformin treated women and their infants had several benefits, including better glycemic control, lower insulin requirements, less gestational weight gain, and fewer cesarean births. And overall surveillance of these infants, again, as a word of caution, is important because I told you these offsprings are going to have little lesser birth weight as compared to placebo or as compared to insulin, and in the long run these offspring need to be followed whether they are going to have a catch up growth. So MITI Kids study has actually looked into that, and they have aimed to examine adiposity in children of women with type 2 diabetes from metformin in women with type 2 diabetes in pregnancy MITI trial. And at 2 years their anthropometric measurements were seen, and this study concluded that anthropometric measurements were absolutely similar in children exposed and those who are not exposed to metformin in utero. So that at least takes away that fear that offspring born out of metformin ingestion by the mother in index pregnancy are likely to have an overgrowth at 2 years and at 9 years. So based on all this, subsequently NS guidelines, FIGO guidelines, and Society for Maternal and Fetal Medicine has said, even including AD and ACE, that although insulin remains a gold standard, still we can use metformin in settings where insulin administration has logistic or compliance issue. Even guidelines as early as 2024 ADS said that although insulin remains a gold standard, but many patients, because of cost, language barrier, comprehension, or cultural influences, who may not be able to take insulin, their metformin remains a very good oral drug option. And of course, potential for growth restriction or acidosis in the setting of placental insufficiency is there. So a word of caution is that metformin should not be used in women with hypertension, preeclampsia, or those who are at a greater risk for intrauterine growth restriction. Our own DIPSI guideline say that it could be used safely after 12 weeks of pregnancy if mother is not keen to take insulin. And 2023 guidelines, for which we were part of writing group, has advocated that we could use metformin after 12 weeks of therapy because it has been found to be absolutely safe. And again, a quote was there that based on our own Indian experience, what is good for conception in PCOD or in other females, even if it is continued during pregnancy, it has been found to be safe. So it could be continues as a very good option versus insulin therapy. A current endocrine practice systematic review by Indian group has looked into long-term impact on offspring at 5 to 11 years of age of metformin use in pregnancy in mothers with diabetes. And it has shown again that metformin used in pregnancy did not show any adverse effects at all compared with insulin on long-term outcomes in children and mothers. So it could be safely used. Although insulin remains the most effective, safe, and time-tested drug, analogs are very, very useful in pregnancy. Maybe Aspart and Lispro, which has been approved earlier, Detimir, but now Degludec has also been approved for use in pregnancy. Even Glargine has been found to be category B. Many of these females, if they are having pre-existing type 1, they could be the best candidate for MDI or maybe pumps so as to get a good glycemic control. A word of, again, in lactation when it comes to breastfeeding, because these days we advocate that every woman must breastfeed so as to have a better immunity for the neonate, that is one, and in advance to prevent subsequent weight gain for the mother also, and further risk of developing GDM if she's lactating maybe for 6 months to 1 year. So we promote breastfeeding in these females, and it has been found if they are on insulin, usually we need to reduce the doses of insulin by 50%. But if they don't want to take insulin at all, even metformin, although it's excreted in the breast milk, but it is has been found to be absolutely safe. It has done no harm to the neonate at all. So to conclude, hyperglycemia in pregnancy or GDM per se is associated with an increased risk of maternal and fetal complication. So it is per se hyperglycemia which we must manage. There is a quote that if we can ensure a glycemic control where fetus will not come to know in utero that mother has diabetes because of euglycemia achieved, probably outcomes are going to be wonderful. So all guidelines recommend today an optimum glycemic control to prevent the risk of maternal fetal complication and improve glucose outcomes. Insulin therapy, of course, remains the gold standard for management of hyperglycemia in pregnancy for females requiring pharmacotherapy. Still, metformin has been found to be safe for use in pregnancy, except for little increase in risk for small for gestational age and prematurity in infants. Of course, we require long-term prospective trial to establish the safety of GDM, but I have given you a very balanced view about safety of metformin based on all current meta-analysis and systematic review which are available. And based on that, AD and ACE guideline 2024 and even our own DIPSI guideline 23 advocate that those patients, those who are not keen for insulin or cannot take insulin because of logistic reason, can be the best candidate for metformin therapy. Thanks a lot for your patience listening. I'll stay back for any question answers. Thanks a lot once again.